I want to welcome everyone to tonight's seminar, sponsored by Shofu. Sponsored by Shofu. Shofu is an incredible company. I love them. They have incredible products. In tonight's seminar, we're going to talk about learning from our mistakes, not just learning from our mistakes, but we're also going to talk about at the time we did things, the materials and the procedures that we have today versus back then. So at the end, we will have a question and answer period. So there's also an important football game tonight. I'm aware of that, being a college football fan. So unfortunately, my team got beat a few weeks ago. And so let's get on with tonight's seminar. So the only real mistake is the one from which we learn nothing. You know, as we go through life, we all make mistakes professionally, personally, and but to learn from them. I know that when I was in college, there was the old saying, well, you'll learn from your mistakes. Well, I didn't want to make mistakes then. You know, I always wanted to get 100% or whatever. But we do learn from our mistakes. So let's take a look at some of the things that we've learned from over the years. All of you will probably recognize this. This has been on all my life, A Christmas Story. And hopefully this young man learned, if you remember, his tongue was stuck to the pole in the Christmas Story. And we still laugh about that. And this is a type of mistake that you definitely will learn from. You'll keep with you the rest of your life. So I just had to insert that to see, to get in here that, yes, we can learn from our mistakes from young to old. So, you know, one of the sayings by Albert Hobart is the greatest mistake a man can ever make is to be afraid of making one. And that's true. We always want to provide what's best for our patients. We're human. I always used to say to my team that if something went wrong or in the schedule or something went wrong with the patient, no one died here. We're okay. The patients will understand. But we're going to talk about how to reduce those, not only learn from our mistakes, but how we reduce those mistakes tonight as well. Sometimes a mistake is a good thing. Obviously, the architecture's had a little mistake here, but you know what? It worked out for best. I don't know how many people would visit that if it wasn't leaning nowadays. So, you know, when I thought about what is a good mistake that was made, you know, it's definitely the Leaning Tower of Pisa. Being Italian, I've not seen that yet, but it is on my bucket list to see that. So this is an example where, yeah, good mistake. Wasn't so bad after all. So, you know, sometimes a mistake can work out for the best. So I want to start off by, first of all, one of the hardest things I had to do after dental school is learn to listen. You know, growing up in an Italian family, the one who won the argument was always the one who yelled the loudest. But in this situation, you know, as all of us know nowadays, it's so important to listen to our patients. When we have a new patient in our office, the first thing I do is after they fill out all their health forms and everything, is I greet them. I introduce myself, greet them, and I get to know them. I start building that relationship, because in order for treatment to be accepted, they have to trust you. And I want to listen. I will have my assistant write things down as we're talking, and I'll go back and revisit that conversation. Now, that interview may only take 10 minutes, but it's probably the most important thing of that day. When I was recently asked to help a large dental office figure out why they were not getting much of their treatment accepted, I asked them, when did they get to meet the doctor as a new patient? It was the fourth or fifth person in the office. And I said, how can you have a patient trust you if you haven't started building that relationship? So we want to start building that relationship the very first thing. When they come in, just take a few minutes, introduce yourself, and welcome them to your office, and ask them, is there anything that's important? Are they experiencing any pain and discomfort? Is there anything that they would like you as their dentist know? And welcome just as if they're your family. So the mistake of not listening to your patients. This is one of my favorite videos that what happens when you don't listen.
Yeah, folks. A large pepperoni pizza.
And a Pepsi, please.
A Pepsi. Sure thing, Curly. Here you go, Cupcake.
Thank you.
Hey, come here. I want you to listen very carefully to what I'm going to tell you. We both know I ordered a Pepsi-Cola. And now you've insulted me and my entire family by offering me this, whatever it is. For being a civilized person, I like to give you a chance to make amends. Capiche?
Yeah. Here you go.
Thank you.
So that's one of my favorite videos. So the whole key here is that sometimes mistakes have the power to turn you into something better than you were before. I think in this situation of the video, the gentleman understands you better listen to the young lady. And the same with our situation with our patients. Sometimes a mistake, whatever that mistake may be, can turn you into something hopefully better. And so I just love playing that video. So let's start off with the mistake of consistency, efficiency, and convenience. I'm going to start with photography in the office. I use a lot of photography. I do a lot of reconstruction, a lot of cosmetic dentistry, and general dentistry. And this is a case on a patient. And I use a lot of photography as I go through this case, not only to document, but also to show befores and afters, and also to teach with as well. And a lot of times it's hard to get the right view, the right angle, the right lighting and everything. So this is what has always been our go-to in dentistry. This is by Canon. And they really, several years ago, put themselves on the map, not only in dentistry, but in all aspects, just because of their single lens reflex. And also they took a digital photography, advanced it past almost everyone. In fact, Kodak almost went bankrupt over this. But the problem with this camera system is that it's the inconvenience. You have these parts here. And when you're in the middle of doing, let's say, a composite or something, you have to grab the camera. So what are the problems? You have to have a knowledge of the single lens reflex. You have to have a knowledge of what lighting system. You have to have a knowledge of what flash, I'm sorry. And you have to have, what f-stop to use. And you can get good at this. Over the years, I've gotten good at this. But you also, again, the flash, the focus, and it's so bulky is that you break sterilization and you go to take the picture. So what has happened? What has changed so that we don't have this situation? Well, Shofu introduced the iSpecial 3, then they went on to introduce the iSpecial 4. And as it says there, it gives a perfect picture every time, and it really does. It's amazing because I don't have to break sterilization. This camera can be completely disinfected. It's protected, and it gives you some beautiful pictures. Let's take a look at some of the things it can do. It has 9 modes. Plus, the difference between when they had the 3 is a lot of doctors requested the videos. So the 4 has the videos. And these are the modes, the 9 standard modes that you can shoot with. And we use these routinely. As you can see here, you have a standard intraoral. Like if you're going to take your AACD photo lineups, you have your intraoral photography for certain distances. If you want to highlight something, you have your face mode, you have your mirror modes. This is so easy. I call it photography for dummies like myself, where all you have to do is pick it up. And if I'm working on something, I grab a little mirror, take a picture. I want to document it. This is the most perfect camera for the office for anyone just to pick up. The receptionist can pick it up, the assistants, the hygienist, they can just pick it up and focus it back and forth and hit the button and take a picture. This is also so excellent in video to document certain things, like you want to show the patient before and afters. But not only that, but legally, you use this camera for documenting. I'm going to show you, as I mentioned, the video on the 4, I'm going to show you some situations. The fact that the camera is water resistant sets it apart because you can disinfect. Whereas with the Canon, you have this large unit and you have to break sterilization. So obviously one of my favorite things to do is to take shades and send to the lab. And I'm going to show you some examples of that. And it's just so easy. Here's a regular Canon. And if you look at it, I never noticed this till this camera came out, to the iSpecial 3 came out and we started using it, is that when you're trying to have your lab technician match the shades, and this is a pretty good shot, but what distracts you are the gums, the gingiva. and also all the other teeth. You don't concentrate on matching 8, 9, 7, 8, 9 there. You get distracted sometimes with the tongue. Obviously, you can block that out, but with the gums as well. And here's another example. And if you go back, you can see that this flashes at one point and this flashes another. So you got to make sure the flash. I know that when I used my can, I used most of the time I'd have the flash on 0. And my lab technician was really 99.9% of the time right on. But he's an incredible lab technician. But to make life simpler, why not use the iSpecial 3? This is a patient that has a temporary implant. Obviously, it's a screwed retained temporary come out. But we're just showing how nice it is, just the same type of view with the iSpecial 4. But when we get serious about shades, this is the shade mode, and you can actually see how you concentrate on the colors of the teeth. Now, for instance, the lab technician cannot see the shade tab there, but I'll show you what we do down the road here. But you see how this mode, the shade mode, blocks everything out, the gingiva and everything, and you just concentrate. It really is. There's why it doesn't matter. You can actually write on the lens as to the shades of what they are. So this has been an incredible adjunct, an incredible addition to everyday clinic in our office, in that I'm not kidding you, they nail that shade 99.9% of the time with just a simple click and flash. You do the shade mode and get just beautiful, beautiful shades. And the lab technicians absolutely love it. And you can actually Bluetooth it to your camera. So again, this is an example. This is with the iSpecial 4. There's the shade, but see what happens when we go and we add that. It just adds so much more if you go back and forth here. So it's just such a beautiful thing. And again, if I'm doing a procedure where I want to document, whether it be a composite or a crown, or if whatever I'm doing, I can just pick it up, cheek retract, take a mirror, and take a picture. It is a must to have in the office. I can't tell you how incredibly easy it is. And again, I call it photography for dummies. Here's a close-up. So the next mistake that we're going to talk about is the mistake of not providing an alternative treatment. You know, over the years, I've been at this a long time. When I was in dental school, we were only allowed to put etch on enamel at that time. We were doing class 3 composites with a mylar strip, and we had adaptic and concise were our 2 composites. That's all we had. We had a base and catalyst. We mixed it together on a little pad, and we would put it in a centric syringe. We had about 2.5 minutes to work with it, inject it into it. But we only etched the enamel. In fact, you usually got an F if you got any etch on dentin that day. And as you all know, nowadays we use etch on dentin like get by the gallon, so to speak. But where composite has gone, I'm presently writing an article on it, and it's amazing where we've gone from being concerned about shrinkage to being concerned about we're always concerned about aesthetics, but now we have bulk fill, and now we're getting into a different type of generation of understanding what actually takes place. So one of the things is that the largest growing population at this time is 80 and over. So what we fight there is xerostomia, gum recession, and root exposure. So, you know, if you have a person that's 80 and over, not many of these people, and these are the causes: soft tissue and osseous consideration, gingival inflammation associated with periodontal disease, and trauma, aggressive brushing or occlusal effect. So a lot of gum recession and root exposure that we see in elderly. This would be a typical, this patient happens to be 87. And if this person was probably in their 40s and it was like this, we would repair that, and we would most likely have the periodontist do a gingival graft. But 87, this person doesn't want to do this. And even at 40s, a lot of times patients say, no, I'm not going to have any gum surgery there. So let's talk about an alternative treatment to that. And that is Shofu's pink porcelain. I've had so much fun with this beautiful, it's called Beautiful 2 Gingiva. And they came out with like 5 major shades. But when you think about it, you can mix those shades. And I'll show you a mixture of shade guide of how you can mix them. And actually I made my own shade buttons. So I just took like a little stick and put some on, and that way I can hold it right in the mouth. But it has the Gingiva technology. I was kidding Rachel today and going to call it Gingiva, but it's Gingiva technology, which is a bioactive technology. And these are the basic shades right here that you can see that we use. But I want to show you what happens is that if you take the LP, mix it with LP with DP, these are the different colored combinations that you have available to you. So you can see here, right along in here, you have multiple shades that are available to you, depending on each patient. Obviously, the same patient doesn't have the same color gingiva, but it is a beautiful addition to it. So this was actually, I love showing this because this was actually the first tooth that I did. And I really love doing this. I have a lot of fun. It's kind of like, you feel like you're almost like Michelangelo, a little artist, and that you're going to try to combine them. So this was my very first one. And I was pretty proud of it. But when I looked at it, I go, you know, today I would do it differently. Obviously, as you learn to work with the materials and everything. And it's really easy to learn, and it's fun. Because what I did was I took the different shades and mixed together and see the results and take pictures of them. But as I gotten better, this is a molar. This patient has a wide smile. And I did everything we could, my assistant, I had to get the saliva out, but it just wouldn't happen. So this patient has this recession here, and the patient was very concerned. It was a little somewhat sensitive to him and didn't like it. Believe it or not, the bicuspid, their number 4 didn't bother him as much, although we did fix that and have decay. But I just want to show you as you start using this, what you can do. So what I did was I used a combination of regular shaded composite with a little mixture, and it has a real nice blend to it. And I really like the effect of this and the way it looks. So you can have a whole lot of fun with this. This is an example of some of the work that can be done with this, and you can see here. So this is just a perfect situation. These slides here show you perfect situations where, you know, the patient may not want to have a graft, and I don't blame them. In this situation, I myself wouldn't want a graft if, depending on the age. You know, I want to address the pathology as why I'm getting these abfractions, but this is a beautiful alternative to that graft situation. And as you can see here on the cuspid, it just turns out so nice. So that right there makes it well worth it. So that's the alternative to treatment. The mistake of not being able to offer that patient alternative treatment and just saying, you know, you're going to go with a graft or observe or do nothing. So that's just the Shofu came out with this, and it's just been one of their great inventions in coming out with this. So let's take a few minutes and talk about the geriatric class 2. Again, as I said, the fastest growing population today is over the age of 80. You know, the baby boomers are over the 70s now. And so the beauty of it is that we better know how to do geriatric dentistry. In our office, we have a very large population of geriatric patients over the age of 75, 80. And so there's a lot of things you have to do that just isn't routine type dentistry. Plus, you have to really evaluate what their health situation is. You know, how healthy are they? If you have a patient that's, you know, you look at the charts, if you have someone that is 75 years old and they are in excellent health, the charts say that they will most likely live to be 88 to 90 years old. So we want to take a look at how healthy they are. If you have someone that, you know, has gone through chemo or is going through chemo, and, you know, they're 75 years old, 80 years old, and they're not in the best of health, the charts might say they only going to live 5 more years. So they present different situations, different scenarios, just because of xerostomia, of recession. And we have to be kind of almost like inventive to treat these patients. So let's take a typical, in this restoration I'm going to show you has been around for years, and that's root decay. So we call it raising the margin or the sandwich technique. So this is what I call the ugly. So root decay, the patient is a geriatric elderly patient. They have root decay, they have dry mouth, And, you know, they come in for a cleaning and every embrasure in this world is packed with food. I know you've all been there. And all of a sudden you look at this root decay and you go, you know, what am I going to do with this? This is not a fun thing. So this patient is 87 years old. And you can see here in 2015 on the left, he had just a little nick there, and 2 years later. So this patient obviously high cavity prone, and yes, xerostomia became an issue between 215 and 217. The other thing is that you see when in geriatric patients is, you know, their manual dexterity and their cognitive, you start seeing declines in that. And so a lot of times these patients will have people bring them. So, you know, their dexterity and keeping things clean. That's why a lot of these patients, for instance, will put on Perio Protect and additional hygiene. For sure, we want them in every 3 months. But you can see here, this got away from this patient. This patient had not been in for 2 years. So how are you going to approach that? Well, and again, this is what we call the ugly. So remember, dentin decays at a pH of 6.2 to 6.5. Enamel starts to demineralize at 5.5. So dentin being softer, obviously, will start decaying at a more of a base than enamel, obviously. So we got to remember these things and this is on exposed dentin and cementum. So for years, we didn't have a whole lot, you know, many types of materials, many types of procedures in treating this. In fact, when I was in dental school, we would probably place a crown or a gold inlay and probably do the root canal. Either that, or we would take zinc phosphate, remove the decay, take zinc phosphate as a base, place an inlay or a crown, and just pray and hope that the tooth doesn't become devital. But in most of these cases, it would probably, looking back, turn into a root canal and a crown. But as time went on and we got away from GV black dentistry, we start realizing how precious enamel and tooth structure was. The manufacturers supplied us with some incredible materials with certain properties that allowed us to give this tooth a longer longevity of vitality. And also, it would give us an opportunity to be very conservative in our preparations and in our procedures for restoring these teeth. So here's the pulp. Again, when I first got out of school, we probably used zinc phosphate. So as time went on, we would have placed a glass ionomer, and then with the sandwich technique, we would have placed a flowable, then a composite. And of course, back in that time, the composite, we would worry about shrinkage. We didn't have a lot of good aesthetics, but the biggest problem would have been matrices and also getting a nice emergence profile. But that would have been one of the approaches we had not that many years ago. And we would have used maybe like I said, some type of non-eugenol pulp protector. I go back to the days when we used Cavitec and Dical. You know, we would have used some type of liner in there. We didn't really know how the vitality of the tooth was going to turn out. But today, you know, with our materials, and no one likes doing these, but it's a fact. So as we advanced in dentistry, there's a certain number of buzzwords around dentistry. And today, I would say the number one buzzword in dentistry is bioactive. What exactly is bioactive? For most part, bioactive materials are either calcium silicates or calcium aluminates, both of which set with an acid-base chemical reactions that produces an alkaline pH. The clinical benefit is fluoride, calcium, phosphate ions are released. They have to come in contact with tissue. The acid neutralizes the acidic. If acidic saliva gets more towards the base, thus you have less demineralization, and you get an elevated pH for remineralization, and a hydroxyapatite formation takes place. So it's amazing when you go back over the evolution of composites, over the evolution of what we call gap closures. You know, our biggest thing is the weakest part of a restoration is not necessarily, is obviously a patient's hygiene, but I always say that, but on the tooth itself, it's that interface of where the material meets the tooth, whether it be the cable surface or the cervical box of a class 2 preparation. So with bioactivity, the companies have shown how we are getting so good at understanding the chemistry and the physiology behind the combination of this material in the tooth of closing what I call that gap, that margin. This is especially beneficial in children, the elderly, and patients with high-risk caries. But I'm thankful that I am able to place this every day in our, patients that if I'm doing an occlusal, it's still important. So let's take a look exactly what Shofu has provided for us. It's beautiful, beautiful 2LS low shrinkage. This is their Gingiva that releases these ions, the fluoride being obviously to fight off decay and to get that increased pH to form a base pH so that acid doesn't take place, so demineralization doesn't take place, and you actually get a remineralization. So this is beautiful, beautiful 2LS, and it's the Gingiva from Shofu. And as it says here, together these ions have been clinically proven to inhibit plaque, neutralize acid, and eliminate secondary decay. And it's pretty amazing where this chemistry has taken us to not only help our patients, but perhaps give us a much better restoration and longevity, and also easier material to work with. It's really exciting. This is the bond we use. This is Beauty Bond. It's a self-etching. I believe it's a 7th generation, has one component of dental adhesive. So that's the beauty of it. When you have these, you and I both know, and I'll show you in a few minutes, part of the problem when you have these restorations and this decay that far deep is being able to cure that way down there, but also etch and rinse. And, are you going to cause more bleeding in the gum and that type of thing? But with a self-etching adhesive, it's a beautiful thing. So this is the flowables with their Gingiva. It's called Beautiful Flow Plus. There's the low flow and the stackable. I use these every day routinely. And this is the Beautiful Flow Plus. The FO3 is low flow and zero flow. The low flow I use in a cervical box. The zero flow I'll use on the occlusal table. So this would be our ideal preparation. You can see here with the low flow with the Gingiva chemistry in it, that it down in that cervical where the patient's supposed to floss and keep clean, but it closes that gap, releasing these ions and strengthening that tooth and healing the tooth and remineralization. So this is our patient. This is the x-ray you saw. This is the 87-year-old patient. And you could not see anything clinic. Here is where we probe. So it's asymptomatic. So here's the challenge of being conservative dentistry. One, the patient is 87 years old. So how should we approach this? Should we do the key approach or, approach it laterally or occlusally? How do you do selective caries removal? How do you protect the pulp? How do you remove the excess tissue? How do you isolate the gingival box and get a great emergence? How does a wedge on wedge against, that's an implant crown next to it. That's not easy. How do you then get a great contact? Do you really charge 2 surfaces for this? I won't charge 2 surfaces, I'll charge more because this obviously, and it depends on the patient, but this is a lot of work and this is going to be a lot of work. So immediately what goes through my mind is I want to approach this. I want to get a great emergence profile. I want to make sure I can remove the decay. I don't want a pulp exposure. I want to protect the pulp. So let's take a look at how we go about this. Step 1, tooth preparation. So we evaluated the lesion laterally and found the decay extended coronally. So therefore, we're not going to go from it laterally. Hence, decide to drop a box using a wedge guard and the essential class 2 burr. So in this situation, because I don't always use an in-cutting burr, but in this I did, I used a lateral diamond with a wedge in there, the classic box preparation, the reusable end cutting. And I also use my Cereburs. Now these Cereburs are excellent. You use them at 1,200. And someone was smart. I don't know why I didn't come up with this. Basically plastic, and it can only remove decay, cannot remove hard tooth structure. So these are a great adjunct to have in the office. I can tell you that it's not unusual. I do not use caries indicator because a lot of times it gives a false positive. And the whole purpose caries, the whole way caries indicator works is it reads soft tooth structure. Well, if you got secondary dent or you got sclerotic dent, it may be soft, but it's not decayed. So you got to be careful. I've often said in lectures that caries indicator can cause more pulp exposures than decay, but you got to just be careful with it. A lot of people I know use it, they're comfortable with it. But this is what I use to get that deep, deep decay out with, is this Cereburst by Comet. Step 2, tissue preparation. This is the laser I use. It's Gemini. It's a wonderful laser. It has dual wavelength. It has an 810 and 980. In fact, I just used it today with a patient that came in with a canker sore. And, you know, it's one of those situations where I really do like this. There's certain things in dentistry and clinical dentistry I couldn't be without. One is the chemistry in our fillings nowadays. I couldn't be without electric handpiece, laser. It's just a couple of the things. So, you know, it's all about multi-use because the hygienists use it, we use it, and it's very portable, this Gemini laser. In this situation, I use TheraCal. Now, today, I would use TheraBase. They just recently came out option to protect that pulp and just to make sure that I'm giving the pulp every chance it can to heal. So let's take a look at elevating the margin. What I did was I created the ideal box. I took a molar band, the old Tofflemeyer band, and I put it right at the gum matrix, and no wedge was required. The band was twisted tight. And this is just to form that initial cervical, deep cervical restoration portion of the restoration. But when I created the ideal box, it was isolated, blotted dry. I applied Beauty Bond for 30 seconds. It has a 5 micron thickness, air dried, and then I cured. Now, here's the problem. When you go to, and I measured that distance on the radiograph, it was 8 millimeters. So the problem comes the distance of curing, improper curing. As we all know, the further away, the less the efficiency of the cure. Also, I wanted to make sure that I had a uniform beam in curing this so that all areas cured. I didn't have to worry about shrinkage, but that all those areas got cured that deep in the gum. After I used the laser, then I was able to do that. So today, I would place Beautiful Flowable or the Pink G. They're both, you know, with the Gingiva chemistry. I allow 5 seconds to self-level. A lot of times when we're doing interproximals, I've seen many clinicians in hands-on where they put the flowable and they don't give it time to settle. Give it a few minutes to settle. One of my concerns is if I take an Explorer probe down in there, I'm going to create a bubble. And I do. I make sure that it's adapted to all the walls. And I want to make sure that I don't have a bubble. Then I would light cure for 30 seconds, realizing that I have good isolation. Today, after this was done, Shofu came out with another great flowable. It's called Fit Self-Adhesive. I would try and put this self-adhesive in where I don't have to etch down in that deep cervical box. That's the beauty of this. And again, this has the Gingiva chemistry in it. So here's 2 of theirs. The SAF10 is a high flow. And obviously SA stands for self-adhesive. And the Fit F103 is the low flow. So in the low flow, I would put down in the box, most likely, but you can also put the F10. So that's just something in addition, and a different alternative. So if you look here, I have that first part done, and the excessive flowable is removed. I use the number 12, Bart Parker, and the box is prepared to gingival level. And this will allow a nice emergence. If you notice, didn't come up. There it is. The flowable Pink G right there. I absolutely loved it. It came out so nice. So the next part is sealing, getting a good matrix. You know, there's a lot of different matrix systems out there. And one of my pet peeves is if they don't take and contour, if the clamp is not contoured to the tooth. And for years we've had to put, like, if you look at this situation here, here's an example of a clamp that doesn't really, and its wedge doesn't really contour to it. So we want to make sure that when we put that sectional matrix in there, that we burnish that contact area. We want to make sure that we establish that contact area where we want it once you place that sectional matrix. And if you look here, sometimes those rings, and this is that example, can insert and overbulk the composite. And it's too close to the gap. I'll show you another example here in a few minutes of where that. Garrison came out with a great composite 3D fusion. I absolutely love their wedges. They're soft and they don't hurt the patient. And they also will adapt sliding into the subgingival area. And these are the rings. Now, the beauty of these 3 rings is that the blue ring is for short teeth, like a bicuspid tall ring, like for molars, or a tall ring. But the bottom one I use often, where you have to open up the contact, you have either a lingual extension or a buccal extension, and that does not infringe on that restoration. So here's an example that I took a picture of a nice bicuspid with that short blue ring, and you can see it adapts very nicely. And here is a molar. And this is where you can see here, this orange one is putting pressure. If you notice on the lingual, the mesiolingual of that, see how that little point there, that rubber part puts pressure on it. That will not give you a nice contour in your restoration. So what we do is we go to the blue. And that's exactly what I was talking about. It gives you a nice cervical margin and contact zone there. So if, in fact, you still can't get it sealed at the gingival margin, what are your options? You can re-prepare your line angle and open them up further to reduce the undercut. So that's another option we have. Many of us will get ready and we put that sectional matrix in there. And we go to do that and we go, I better extend that margin a little bit more. The class 2 placement, the wedges, and this is exactly what we did here. So the process, we use the premolar band with extension, the wide band, and the wedge. Also must consider bulk folds such as other composites when we do this. But I love, in this situation, the Gingiva and what it does, because I know that I'm going to get fluoride and I know I'm going to get a low pH release. And then today, if I did it, or I did use the selfetch beauty bond, but I might consider the fit SA, and it cured at 2 to 3 millimeter increments. And you can see here. So then I use it truly is one of the favorite items that Shofu makes is their super snaps. I use those routinely in the interproximal, towards the buccal, towards the lingual, to polish my composite restorations. And this, you can see here, it turned out very nicely. Here's our x-ray. You can see the emergence profile, and very happy with the results. So if we go back, we placed Pink G Flow, beautiful flow, beautiful flow, beautiful 2, and with the Gingiva chemistry in it. And I placed a little Theracal there. So it turned out nice. Again, this is an example, if you go back to when we would have done a gold inlay, and even today, that would have been an acceptable restoration. But we want to be as aesthetically conservative as we can be. You see here, there's still a lot of solid tooth left here. So far, patient's doing great. So let's go on to our next mistake, the mistake of not being able to provide a definitive diagnosis. Results, possibly the incorrect diagnosis results in correct treatment provided. What exactly am I talking about here? The mistake of not having a CBCT in the office. You know, for years, we would use full mouth series of x-rays, but we're dealing with 2D. I cannot stress enough how important, like every new patient gets a CBCT in our office. I cannot express how much more dentistry we've seen, how much more disease, how much more we have been able to take our patients and give them a definitive diagnosis. The patients are so happy when they don't have to go somewhere else and take a CBCT. And they also are very happy when we can give them a definitive diagnosis. Let me share with you a couple of examples. This was only about 6 months ago. This patient came in and said, you know, once in a while, right here on my upper left, I get a bump here. And he had told the hygienist took the PA, walked into the room, and the patient says, you know, I get this swelling. Well, here's a previous root canal. But the question that comes up is, can we give a definitive diagnosis here? We really can't. We're guessing. You know, we're flipping a coin, we're guessing. And we don't know what's going on. Yeah, we can see some areas right up here of infection. So right away, I turn to and take, with our Prexion, I take a CBCT. This is the typical picture that you get from a CBCT. And believe me, you may be sitting there thinking, oh, I would never be able to read this. I'll never be able to use it. Trust me when I say, if you can read 2D, you can in a short period of time. And you get education tapes with this. You get a little USB that gives you step by step. And you learn how to read. You have the capability, the knowledge, and the know-how. So this is what we get when we take a CBCT. The upper left panel is what we call the axial view. Obviously, to the right is the 3D skeletal view. The below on the left is the sagittal view, and the below on the right is the cervical view. So we know that this is number 13. So I'm going to take these crosshairs and I'm going to place it on that 13. And as I place it and crank it, every one of the views focuses on that tooth. So all these views would turn up that view. The sagittal, I should say the sagittal and the cervical will bring up that tooth in their particular view. So then what we do is we take that, here's the axial view that we get. We take that and we focus up and down. So here's tooth 13, and yes, we do have a periapical lesion there. And there in that view, it doesn't show you the root canal part. So the question is, how far does this? Now, for most part, we would send this to the endodontist. We would make a diagnosis. Oh, you have to see the endodontist and maybe have a new root canal done. But you also want to check and see if there's a crack or a fracture. Usually in this scenario with that type of infection, there's not. But is there more to it? And that's why you focus up and down. And here you can see it as you focus in. And as it approaches the sinus, you start wondering, because what's going to happen is your diagnosis is going to change. If you didn't have this CBCT and you just had the 2D, then your focus would just be on the 2D. You could not make a definitive diagnosis. You are guessing, there's no question, and you're going to look. But so as we focus a little more, lo and behold, it is into the sinus. So now it's going to call for an antibiotic. It's going to call for just a little different scenario, because how much is it infecting that sinus? So this is an example of why we have a CBCT and how we can provide our patients with a definitive diagnosis. This is just one example. Again, I can't emphasize the amount of dentistry we see. So when a new patient comes in, after I have the interview, my assistant will take the CBCT. As they're taking their vertical bite wings, then I will be studying and reading the CBCT. So I review every root canal. I check out third molars. If it's a possibility that we have a space there, we're going to do an implant. I look and find the nerve, where the nerve is, on and on. If it's a younger person and we're going to be extracting wisdom teeth, I look for the nerve. Where's that nerve at in relation to that wisdom tooth? So let's take a look at this case, this same situation. This patient came in, said, I'm a patient at a dentist. For months, I've been in discomfort. We cannot figure out, he doesn't see anything. He says there's maybe something going on, but put me on antibiotics, but I'm still having the pain and discomfort. So you're the patient and you're going through this, and this is the 2D x-ray. Now, there's no question that in 13 and 14, maybe something's going on, but we don't know for sure. There's not a definitive diagnosis at all. And it's frustrating for the patient. So the patient got a hold of our office, came in, made an appointment. And again, as I said earlier, you're flipping a coin. This is the limitations of 2D X-ray. This is the limitations of only not just 2D X-ray, but not being able to provide. This type of thing used to drive me nuts before I started working with a CBCT, because I'd have to take this patient, send them somewhere, get a 3D or to the endodontist, and I could not provide for them the treatment or diagnosis that I wanted to. So lo and behold, again, is this a good day or a bad day for you? I'm pulling my hair out. I don't know about you guys, but I am pulling my hair out, going absolutely bonkers. And so lo and behold, we take the 3D, and you can obviously see here, we've got some major resorption going on. So the patient was finally happy. We could help them provide a treatment plan for them, help them figure out what to do. And obviously these teeth, for most part, could not be saved. But it's amazing, though, how you can, we've saved somewhere the resorption, especially like recently did a cuspid, where we would have the periodontist flap it. We were there, remove the decay or the resorption, and place a glass ionomer of some type to do a cavity prep. So this is the type of thing, this is the alternative of not having a CBCT. It's a big mistake not to. So in closing, what I want to say is easy to judge mistakes of others. It's difficult is to recognize your own mistakes. You know, dentistry is advancing so much. Again, you know, we're looking at bioactive materials. We're being able to close that gap to prevent secondary decay. You know, we're able to provide better fillings. We're able to be more aesthetic. We're able to be more conservative in our tooth building, fillings back to normal tooth contour. We're just so much more conservative, and it's because of the manufacturers. And, you know, Shofu, for example, who's obviously sponsoring this, has such a line of materials, not just their camera, but a line of composite materials with the Gingiva configuration, the bioactivity, that not only helps us as a dentist to provide a longer lasting, a better fitting restoration, but also gives the patient the health that they've been searching for. Again, as time has gone on, the largest population is 80 and over. And as this population grows, we have to be able to provide materials, alternatives. So, you know, tonight we talked about a number of areas of mistakes of not just listening to our patient, the mistake of that, but also the mistake of not being able to give them an alternative treatment, the mistake of not being able to provide a definitive diagnosis. And so it goes on and on. But again, it's easy to judge others' mistakes. We don't know what maybe one of our colleagues, when we do evaluations, what one of our colleagues has gone through to provide a care that may not look too nice to us when that patient comes in for a second opinion. But don't necessarily just judge our colleagues. So Vincent van Gogh said, success is sometimes the outcome of a whole string of failures. And that's so true. When I think of things like composites, going from a two composite, adaptic and concise in 1980, 1978, 79, and 80, to only etch and enamel. I think about implants, and, you know, when they used to put blades in, and when you look at some of the old blades, and, you know, when we didn't have the grafting material, we had that they would go into surgery and take it from the hip, or they would use, I remember one time I was in the Alabama implant group, we down there early, and at one of the offices, we used plaster from the lab to try to get hydroxyapatite and bone to form. So dentistry comes a long way. I say when I graduated from dental school, you didn't have to know much about materials, but nowadays things change so much that you have to have, a lot. You have to not only know a lot, you almost have to have a PhD in dental materials. But we're responsible as professionals to keep up with this. We're responsible to provide the very best for our patients. And so hopefully some of the mistakes and some of the new type of procedures and materials that you've seen tonight, you will take and add to them and provide for your patients that kind of care. So I just always like to say, you know, talking about making mistakes, these are 4 children. This is about 5 years ago. I should update that. We all make mistakes, believe me. When I look back as a parent and raising children, and I've been blessed for 42 years with a beautiful wife. And, you know, sometimes the mistake of taking certain things for granted and complaining, you know, we all have stress and pressure in the dental office. There's no question about it. There's no question that what we do for a living, it's very stressful. But I can tell you that now I'm very comfortable that, you know, yeah, I do get stressed at time. I do very concerned about my patients, providing them the very best. But also we have to learn from these mistakes. You know, I'm starting my 42nd year and I'm more excited about dentistry. I have to tell you, I'm more excited about dentistry. I tried to retire about 5 years ago and Dr. Lou Graham says, no, you're not retiring, you're coming here. And so we practice together with some other great doctors. And, you know, we have a lot of fun for the most part, but there's certain things in life that the mistake of taking certain things for granted and complaining, that's just, you know, where we live and the things we do and the opportunity we have as professions. We have a better opportunity to change people's lives than so many other healthcare providers. So one of those things that we take for granted is those that have sacrificed our lambs. So for every lecture I get, I always honor those that have gone on before us that paid the ultimate price. So really, I have no right to complain. I mean, these people gave their life for what we are able to do today. So when you think you're complaining, you're stressed, you're having a bad day, just be thankful for you having the profession you have, the opportunity you have, and perhaps the family you have. So I want to thank everyone for attending tonight. Hopefully you learned a few nuggets here and there. And I am going to put up, I also invite you to call me anytime. Please do. If you have a question, this is my email, but don't hesitate to call because I love calls. I love sharing. Because I learn from you all. So Trung, let's have some questions and answers. Hello?
Yes, Dr. Tomaro, go ahead and click the Q&A button.
Oh, wait, there it is. I am so sorry. I got it. There's 3 questions. What's the name of the camera and software you recommended? It is the iSpecial 4 by Shofu. Nina. What CBCT? We love our Prexion. You know, there's a lot of great CBCTs out there, but we love our Prexion basically because it's so easy to use. I cannot tell you. And the education and the support for it is tremendous. Next question, the cases you showed us, how would you bill if not as a class 2? Well, I would probably, first of all, I would for sure build it out as a DOBL, okay, as a 4th surface. Because I teach a business course and it actually is my favorite course. I grew up in a very strict Italian father business. And so the deal is that we shouldn't think of ourselves as like a tool person or a car mechanic. We should really think of ourselves more as attorneys because how do attorneys bill you? Their time. And that's basically, I know that we have insurance companies that you have to bill out, but you have to take it and look at certain things as to how much time. And, you know, obviously you don't want to break the law. You want to obey it and not get burned by insurance and do anything dishonest, please. But in this situation, it would be very acceptable to build this out as a DOBL, at least a 3 surface, not a 4 surface. And Angela says, thank you. Great information. Thank you, Angela. So again, the camera is the Shofu iSpecial 4. You will absolutely love it. And when I say, if you have young children, a 10-year-old, an 8-year-old, they can learn how to use this. And the modes are so easy. I mean, and when I first started learning it, I didn't want to read it, so I went on YouTube and learned the procedure there. Any other questions? We actually got done 5 minutes early. So I just want to go over the, just real quick. So with the sandwich technique, for years we would use glass ionomer, then a flowable, then composite. And now that they have the bioactivity, you want that bioactivity down there. And that's why I put the Gingiva composite down there. But the key is, again, make sure you get the emergence profile. The key, as you all know, obviously, in so many of our class 2 composites, is having the right matrix in there and the right wedge and the right clamp to hold that in there. So you all have my phone number. I'm going to move this to the side if I can. There it is. Phone number and email. I want to thank everyone for attending. Trung, anything else? All right. And again, if anyone has any question, here's my email if you think of something later. Okay, you guys all have a good evening and go watch that football game. All right. Thank you.